I just want to thank you for inviting us up here today. I'm from Washington, D.C. Thanks for not throwing anything. It's great to be in New Jersey. I'm a lifetime Yankees fan. If that means anything to anyone here. My dad was born in the Bronx and I grew up in Connecticut, so I have an appreciation for some of the things that you all care about. But today I want to tell you a little bit about the Affordable Care Act and talk specifically about the cost containment. And I'm going to surprise a few people here. Those are not the same thing. We'll get into the reasons why, but the Affordable Care Act is more about coverage than it is about cost containment. So, just to give you a little background about some of my coalition's members, we are largely an employer-based organization. We do have payers, we have patient groups, and we have provider organizations. And the reason we came together in 2001 was around a singular focus, and that was making health coverage more affordable. So someone asked me before the event, so what do you guys care about? And I said, well, think about healthcare and think about problems in healthcare. If there's a problem in healthcare, we probably have a solution that tries to address it in terms of making it more affordable, less costly. But when we were formed originally in 2001, we really came together around the concept of refundable and advanceable tax credits for individuals to help them better afford their coverage. Well, what's the main subsidy mechanism in the Affordable Care Act? A refundable, advanceable tax credit for coverage. So in 2010, in the winter, my board decided that we would shift focus and begin really emphasizing what's happening on medical cost trends. And what's really driving up healthcare costs that are passed along to premium holders, premium payers, and families and individuals. And so, like I said, I'm from Washington, D.C., and I see some interesting politics going on around the Affordable Care Act. And sorry, just to back up 1 second. I'm basically going to talk about the impact of the Affordable Care Act on a couple of different constituencies. I think Ward's going to talk more about some of the mechanics, how it operates. But I think we're pretty complementary. But what I see in the political side, and I worked on Capitol Hill for about 12 years before joining CHC, is that Republicans are kind of in this state where they think that we just repeal the Affordable Care Act and we can go back to something that's like wine and roses and the birds sing and there's rainbows. And so they're very reluctant to do things that quote-unquote fix the Affordable Care Act. Minor changes that would address real problems associated with the implementation of the law. Democrats, what I see is the law is perfect. A lot of them will say that. But we're starting to see comments like this from the chairman of the Finance Committee, and Senator Baucus said a couple of weeks ago, I just see a huge train wreck. Huge train wreck. And we're starting to hear backroom conversations from some of the Democrats that they're very concerned about how the Affordable Care Act is being rolled out and how it's being implemented and the impact that it's going to have on their constituents. I think there's a real concern about what some of the political backlash would be in terms of the cost increases that are going to be faced, that are going to be experienced by a lot of people. And it's unclear to me whether that backlash is going to be turned against insurance companies, because like it or not, people love to hate insurers. And I have insurers in my group. Or whether that anger is going to be turned against lawmakers who created the law in the first place, and some of the dynamics that go on. So you probably can't see this. We're going to put it up on our website so that you can access it. It's cahc.net. But basically within the next 7 months, between now and January, a lot of things have to fall into place, and a lot of things have to happen almost flawlessly for people to be able to access, understand what benefits are available to them, sign up and enroll online, and then have data and other systems working perfectly to determine whether or not individuals are eligible for subsidies on the premium side, eligible for cost-sharing reductions in terms of the benefit design, and just at a very basic level, that they're able to understand these choices. Okay? Now, I've been in Washington, D.C. for about 25 years. Don't blame me for everything. But one of the things I worked on back in 2003 was the Medicare Part D benefit. And then I was the staff director of the Ways and Means Health Subcommittee through 2006, and I saw how that was rolled out. Now what we were talking about was a new model, a competitive model, where companies would be at risk for delivering a benefit, but it was still a Medicare benefit, and it was attached to an existing program. And seniors felt very comfortable with Medicare, right? It was a known quantity. I think what we're heading into right now is a period of significant uncertainty about who is supposed to be doing what, when, and how. Okay? I'm talking about insurers, I'm talking about states, I'm talking about exchanges, I'm talking about employers, and ultimately people who are going to sign up for coverage. And so this confusion is breeding some uncertainty that's creating, I think, some of the political responses that we're seeing from Republicans and Democrats. But basically, if all goes well, the exchanges are set up, insurers are able to price their products, in some cases with unknown rules, regulations still hanging out there. They're determining what markets to enter. For example, in Colorado, just today, this morning, 17 plans submitted 833 different plan options on the Colorado Exchange. I don't know if they'll all be approved, but that's quite a selection. And we're starting to see what some of the rates look like. So Maryland, for example, just published their rates a couple of weeks ago. It is, for the products available in Maryland, we're looking at premium increases between 25% for the largest insurance carrier to 139%. Okay. Rhode Island, a little different. Rhode Island goes to their rates, 3 to 8%. So it's going to be very significantly across states, and consumers are going to have to make these choices. You probably can't see that either. But basically, what I was trying to show you here is that this is just a list of all the major regulations and where they stand in the process. And employer mandate, individual mandate, exchanges, subsidies, market rules, essential health benefits, some of the premium rules, where we are with wellness for group health plans, navigators, etc. If you look at the dates, most of the proposed rules were either done late 2012 or early 2013. Now, there's some TBDs in the final rule category, so we're still waiting on final rules for some of the major rules. But here we can see most of the final rules have been put out in February, March, or April. Okay? Exchanges and the online enrollment process is supposed to be set up in October. Okay, so there's a very short time between when the final rules are coming out, when people know what it is they have to do, and when those things have to be operationalized. And so the question I have is, are the states ready? Right? We know a lot of the states have made selections in terms of Medicaid, but there's only one state, Connecticut, I had nothing to do with it, that has passed laws to basically effectuate all the market changes, harmonized with the Affordable Care Act's market changes. 11 have passed one, 38 have passed none. Guess where New Jersey is? Are the exchanges ready? Okay, a lot of states agonized over this decision for a long time. There was legitimate disagreement on both sides about whether states should set up an exchange. And so 18 states decided that they were going to run their own. And you had states as diverse as California, for example, who said we are going to super regulate how the exchanges operate. Right? In fact, we're going to make the outside market, outside of the exchange market, look almost identical to the inside the exchange market. So kind of market in California is going to be very uniform. To other states like Idaho or Utah, or very conservative states, who wanted to be in control of their marketplace. Right? They thought that setting up their exchange would allow them to promote a competitive market that they historically had supported. But the majority of states said, no, we're not going to do it, we'll kick it to the feds. So that means 7 states are going to partner with the federal government on a partnership exchange, and 20 states are going to allow the federal government to run the exchange. Okay? So New Jersey is in the last category. Feds are going to run the exchange. And we'll get to what Governor Christie has said about that. But what this means is that HHS, more specifically CMS, the Centers for Medicare and Medicaid Services, has to come in with resources to ensure that the federal exchange works well, and they've got to do it in your state. Here's the problem. They didn't budget for the operation of the federal exchanges in the Affordable Care Act. And so they're scrambling to draw money from the Prevention Trust Fund and other sources to have the resources on the ground to operationalize exchanges in a majority of the states. So a real operational challenge there. From an employer standpoint, I think that there's several different perspectives here, but I guess what I would point out just very broadly, large employers are very focused on wellness prevention programs. Small employers are really looking at reducing hours, lowering hiring, or even discontinuing coverage. Did you have a question? Oh. No. I was up early this morning. Yeah, there's a lot of people scratching their heads. But the interesting thing, a couple of broad trends, and I took this from a survey of large and small employers that started in 2010. 90% have kind of moved beyond this wait-and-see stance, right? They feel like they know a sufficient amount about the law, even though all the rules aren't out yet, to start to comply or activate compliance steps. 64% have analyzed the cost impact specific to their company and their employees. And the interesting finding from the survey is that they think it's only a 3 to 4% cost increase, which is really low compared to the surveys, the private surveys that we're getting from specific insurers, confidential surveys of specific insurers in specific markets. Most employers will retain coverage, at least in the near term, but they are implementing both cost and benefit changes for a number of different reasons. So a lot of the costs will be shifted onto the employees, the individuals and families in the way of premium increases, increased premium share, increased cost sharing, higher out-of-pocket limits, to the extent that you make that fit within the ACA's required benefits. 17% are working to avoid the Cadillac tax, which applies in 2018. And Cadillac tax, I don't know how many people still understand that from the younger generation. Lamborghini tax or something like that. Or the way it's constructed, maybe it should be a Volkswagen tax. But 17% of employers are looking to avoid the Cadillac tax. And the biggest way they're doing that is trying to reduce their benefit generosity, maybe moving down closer towards a lower level plan, bronze plan. Again, mostly for the small employers, 16% have already adjusted hours so that fewer workers will qualify as full-time employees. Okay, exactly the last thing that we want to have happen, right? Particularly for small businesses, the engines of job creation. We want incentives to increase hours, increase employment, increase hiring, not scale back. But it's having that impact because the more full-time employees you have, the closer you get to the employer mandate, you have to comply with a whole bunch of different requirements. We did our own research in 2011. We took a look at what's going on with healthcare costs. I encourage you to go to our website and read the study. But basically, we took a look historically at what healthcare costs have done to the unemployment rate and labor markets in particular. And we said back then it might have added 2 full percentage points to the unemployment rate at that time. And we think there's a direct correlation between increased health costs and unemployment. So what will be the impact on costs? And this is the California Insurance Commissioner. I can't read it, I'll read it for you. We're very concerned about what will happen if essentially there's so much rate shock for young people, they're bound not to purchase health insurance at all. Each quote that I've shown you are from Democrats. There is a huge concern about this. What we see in the younger generation culturally is that they're putting off big purchases. They're not buying houses, they're not even buying cars, they're using the zip cars and things like that. If they're faced with a plan that is too expensive, they'll put it off because the penalties on the individual mandate side are not significant at all to, I think, elicit a big behavioral response. So you've got kind of like this whipsaw effect here. On the downside, you've got premium subsidies and cost-sharing subsidies. You've got reinsurance, and you've got hopefully more people getting into the pool. This is going to generally tend to make costs go lower. The problem is with premium and cost-sharing subsidies is that cost shifting is not cost containment. Shifting the cost onto a taxpayer to pick up a subsidy for a more expensive health plan is kind of a weird strategy. Why don't we make the health plan less expensive by addressing medical cost trend? And then we can think about how's the best way to subsidize it. On the increased cost side, there's been a lot of studies about this. Milliman, AHIP, lots of actuaries have looked at this. Insurance taxes, essential health benefits, age rating, pre-existing condition exclusions, guarantee issue, individual mandate, and medical cost trend are all going to add to the cost. And the question is, how does that whipsaw or teeter-totter fare out for the average person?